Right, I'm going to get us started. Lauren, are we recording?
Yes, you are recording and all set to go.
Awesome. So hello, everyone. Welcome to ASBH's webinar, When Immigration Enforcement Comes to Our Hospitals and Schools, Considerations for Ethics and Policy. This webinar is a part of our ongoing series, Building Diversity, Equity, and Inclusion, DEI into Bioethics and Health Humanities Scholarship and Practice. All webinars are available to the public for free, and recordings of all webinars are available on ASBH's website. Today, we are happy to welcome Matthew Lopas, Thalia Porteny, and Altaf Saadi. Matthew Lopas is the Director of State Advocacy and Technical Assistance at the National Immigration Law Center. His work supports activists and advocates seeking to create change on issues affecting low-income immigrants at the state and local levels. This includes managing projects and campaigns that build power arising from affected communities, including NILC's work at building a path to health for all. He has worked as an attorney at the intersection of health and immigration for over a decade, serving as a national resource for the implementation of the Affordable Care Act for immigrants at the state and local level, advocating for federal legislative and administrative change, and educating stakeholders on the rights and healthcare providers in establishing safe facilities for immigrant patients. Thalia Porteny is an assistant professor in the Department of Health Policy and Management at the Mailman School of Public Health at Columbia University. Dr. Porteny is a health policy scholar and applied ethicist. Her interests are motivated by the needs she saw growing up in Mexico and working in the Mexican Ministry of Health. Drawing from ethics, health services research, and implementation science, she employs qualitative and quantitative methods in her investigations. Her work aims to better understand the health needs and experiences of vulnerable populations, primarily older adults, migrants, and to advance fairer patient treatment, allocation, and access to health resources. Finally, Dr. Altaf Saadi is an associate professor of neurology at Harvard Medical School, a neurologist at Massachusetts General Hospital, and the associate director of the MGH Asylum Clinic, which is a clinic providing medical evaluations for U.S. asylum seekers and survivors of torture. Her research, clinical work, and advocacy efforts are dedicated to addressing the needs of immigrants, forcibly displaced people, and justice-involved individuals. Dr. Saadi's work has been instrumental in advancing the concept of sanctuary or immigrant-inclusive healthcare spaces, evaluating health conditions and harms in immigration detention centers across the United States, and fostering practitioner research partnerships with civil and human rights organizations, such as the American Civil Liberties Union and Physicians for Human Rights. Finally, we are grateful to Victoria Tejada and Suzanne Lightbourne for providing ASL support for this webinar. And so I'll turn it over to Matthew Lopas for some preliminary remarks.
Great, thank you. And let me just get my slides ready for you all, and I will begin. Okay. Oops. Great. Right. Hello, everyone, and thank you for having me. My name is Matthew Lopas. Oops. Ooh, I accidentally. And I am always glad to be speaking with physicians and such great presenters. So thank you very much for having me. What I'm going to be talking today is about some of the law and policy issues related to immigrant access in health and education programs under the current administration. The Trump administration has made drastic changes in the last few months, in the first 6 months of the administration. It has taken steps to end programs that end programs like temporary protected status and parole, basically humanitarian programs from people from countries where they may fear being able to return because of either instability or fear of persecution. And by doing so, this has rendered them undocumented, despite some folks having really built a life here in this country. Oh, sorry, my slides have stopped sharing. They keep doing that. Thank you for the heads up. Let me try that again. There. Are we good? Okay, good. Sorry about that. In addition, the administration has really been taking a more militaristic approach to deportations and the enforcement of immigration law. Plenty of this has been on the news lately, issues of agents in masks that are showing up and taking people into custody, not always people from Immigration and Customs Enforcement or ICE, but sometimes other federal agencies as well that have been brought into this process. There's been an expansion of the tactics that the administration is using, such as, very importantly, a broad use of what's called expedited removal, which essentially means that certain people end up being removed from the country with no due process, no ability to see a judge in immigration court, and really no attempt to make their case, even if they may possibly be able to get a legal status. And the reason that many in the education and health field in particular have been concerned with this new administration is because of the rescission of of what's called the protected areas or sensitive location memo. This was policy going back to 2011 that said that certain places were so important that they were shielded from immigration action, even when increased enforcement was happening. This I like to emphasize was really always just a policy, though, and it was an important policy because it put some restraints and some guidance to officers in the field, but it was never an enforceable legal mechanism to keep officers out of these types of facility. What did not change with the new president was the law that governs access to these locations. The legal protections are governed by the Fourth Amendment, which protects against unreasonable search and seizures. What's important to note is that healthcare providers and educators in both of these situations, sorry, I mostly talk to healthcare providers, so I always have to remember I need to throw in educators when I'm speaking to a broader audience. Healthcare providers and educators both can refuse to allow entry by law enforcement officials into private areas without a proper judicial warrant signed by a judge, unless an authorized person consents. All of these words have some level of importance, but the idea is that there are some places open to the public, and there are some places where there's a restriction on who's able to go into those places. And when there's a restriction on who goes into those places, you can require immigration enforcement to have a warrant and able to go in there. There's a lot of information that we have on our website about how to follow procedures, but the main idea is an authorized person or legal counsel should really be trained on those. Right now, there's a lot happening that could make things much worse. There's a bill in Congress that would increase funding for enforcement of immigration by $150 billion. This is combined with quotas that are already in effect. We are not hitting those quotas yet that the administration wanted. So we can expect that with more money and more attempts to reach those quotas, that immigration enforcement near schools and hospitals is likely to increase. We have already seen some officers near schools. We have had them here in DC attempt to go into schools not for students, but for others. So that is likely to just increase. And there are also really negative cuts to access in the reconciliation bill that would strip many folks from their access to healthcare and make it harder for hospitals to do their job. But it doesn't have to become law. There are still things that can be done. Congress has not passed this law yet. There are some things that folks should know what they can do. Essentially, the main thing I would say is to continue doing your job as best you can to help your patients, because it is such an important time for folks. But when we're talking about things steps that can be taken, these are rights that you can enforce. It is within your constitutional rights to enforce these protections for private spaces, to choose not to speak when you feel like you you would rather not talk about something with a law enforcement officer. You can also inform your patients and others about their rights, provide know your rights material, provide some informative information. And you can record and document things that are happening if you happen to be there when some sort of enforcement action is happening. Just make sure that you're careful of privacy, not violating, if you're a healthcare provider, any HIPAA laws, and also make sure you don't interfere or aid law enforcement in their actions. This is such an important time. Mental health, schools, just broad healthcare in general are going to be incredibly important to immigrants and their families. So following steps that we can discuss more if you have questions, and we can otherwise share in some of the resources that you've already seen, will be may create opportunities for you to take steps to meet your patients where they're at. So that's it for me. We'll make sure you get links to some of these resources. I see they're already in the chat. And thank you. I look forward to questions.
Thank you, Matthew. Thalia, we'll have you go next.
Perfect. Thank you. Well, thanks again for this wonderful invitation. I guess what I wanted to cover, and I don't have any slides, I just have some remarks, but this important question of what could and should guide ethical policy and practice in an era of increased immigration enforcement. And first, I want to begin by saying that I draw on a membership-based account of justice, and this was first developed by Norman Daniels and Karen Ladine. And what I'm hoping to do today is apply that framework to contemporary health policy questions, especially those that affect undocumented immigrants. And because I find this framework becomes especially compelling at this time when migration policy is actively reshaping access to health. So let me begin by explaining some concepts. Traditionally, migration policy refers to how governments regulate borders, visas, and enforcements. So who can enter, stay, or work in a country. And migrant health policy, by contrast, this refers to how health systems respond to the needs of migrants. So who can enroll in coverage, what services are available, and under what conditions. And so in theory, these two domains are distinct. But in practice, and this isn't necessarily new today, but I do think there's some level of enhancement now. Migration policy is gravely affecting migrant health policy. And this is happening often in harmful ways. And so some states now require hospitals to ask their patients for their immigration status. Importantly, people are not required to answer, but still, I think this can be something that makes people afraid to go to hospitals, and it just creates a lot of confusion. ICE can now go inside hospitals and other healthcare settings. Sanctuary protections have been rolled back in many places where there were these sanctuary protections. And fear of detention or deportation, this really prevents many migrants, both documented and undocumented, from seeking care, even when they're eligible. There's just a huge increase of misinformation, and undocumented immigrants and migrants more broadly. There are often the targets of this misinformation, and as it relates to healthcare as well. And so I think that this entanglement really has created a landscape in which undocumented immigrants face barriers to basic health protections. And this demands an ethical framework that can help us navigate this reality. At the same time, I'm very much an applied person, a realist, and I think we need to be honest about the political landscape. And so there's this widespread opposition to expanding access to care for undocumented immigrants. So a national poll found that nearly 60% of respondents opposed government-sponsored health coverage for undocumented individuals. And so I like to ask myself, why? What are the arguments? What are the justifications, the rationales for this? And so often these justifications say that they haven't paid into the system, they broke the law, we should take care of our own first. And some comments go even further. So one transplant physician in Texas, and this wasn't his view, I should say that he was just explaining, kind of the atmosphere there. He said, Texas doesn't endorse free medical care to illegal aliens, they all die. So these views, I think they're very disturbing. At the same time, they're not fringe. They're shaping how hospitals, states, and policymakers think about eligibility. And so this is why I think we need a persuasive ethical account. Not one rooted in abstract appeals to global justice, but one that engages with these concerns directly. That's where I think the principle of reciprocity comes in. So the membership-based account of justice that I was speaking about before, it says that people who are socially embedded members of our society, so those who live, work, pay taxes, raise children, they're not outsiders. They're actually members of society. And as members, they are morally entitled to protection, including protection to their health. But where I think this framework becomes especially persuasive now is through this idea of reciprocity. And so Daniels and Ladin, they argue people who contribute to society ought to be eligible for the benefits their contributions make possible. And this is what reciprocity requires. And I think that reciprocity is especially useful when migration and health are politically entangled, because it speaks directly to public concerns about fairness and obligation. So if undocumented immigrants are helping sustain public systems, then a just society has an obligation to ensure that they benefit from those systems in return. So this isn't about innocence, it's about mutual responsibility in a shared society. And so let me give just some evidence about contributions. So undocumented immigrants, they contribute over $11 billion in state and local taxes in just like a year. This is from 2017. They also pay into federal programs like Social Security and Medicare, in spite being ineligible for many of these benefits. There's an Omer-born study from 2022 published in JAMA Network Open, and it found that US-born individuals had a net healthcare deficit of about $1,139 per person, and immigrants, undocumented included, had a net surplus of $1,123 per person. So undocumented immigrants, they aren't draining the system, they're very much contributing to it. Yet when they get sick or need long-term care, they're often excluded from coverage, from specialty services, and so on. And I think this is a failure of reciprocity. At the same time, we're accepting their contributions. Another illustrative example where I've done a bit of work is organ transplants. So there is no federal exclusion that prohibits undocumented immigrants from receiving organ transplants. There's a lot of state variability in these policies for sure. And I just want to say that much gets decided at the transplant center level. Still, hospitals often require proof of insurance and ability to pay for post-operative care. And this is criteria that many undocumented families cannot meet. And as a result, children who have lived their entire lives in the US, attending schools, growing up in mixed status families, sometimes they can be denied life-saving transplants in spite of, showing that there aren't any differences in outcomes, and other types of important measures. And at the same time, their families, their communities, they contribute to the organ donation system. So at least 3% of the deceased organ donors are from the undocumented population. And I do say at least because about 7% have unknown citizenship status. And at the same time, they receive less than 1%. So I think this is like one example of an ethical failure. And this failure, I think this extends beyond life or death cases like transplants. It shows up in other areas of care, which I'm sure many people today, are part of, kind of like providing chronic disease management and so on. And it also shows up in mental health harms that immigration enforcement produces. So there is strong evidence now, and I think more is to follow, that children of detained or deported parents experience PTSD symptoms. They have trouble sleeping, heightened fear, chronic anxiety. Pregnant immigrant women exposed to restrictive enforcement environments are more likely to have preterm or low birth weight births. Immigrants, even those eligible for care, they often avoid mental health services out of fear of surveillance or immigration consequences. And I don't think these are just unfortunate side effects. These are predictable outcomes of policy decisions, and they disproportionately harm people who are already giving to society. Reciprocity, I think, demands that we not only stop these harms, but actively protect those who are making contributions despite risk. So one last point, and I think this is very well articulated as well by Daniels and Ladine, is a common objection is that undocumented immigrants broke the law and that they shouldn't benefit from public systems. At the same time, we don't deny healthcare to people who've broken other laws. If someone steals a car, they still are eligible to get cancer treatment. If someone evades taxes, they're still eligible for emergency surgery. So I think immigration violations are often civil offenses, not crimes. And even if they were crimes, withholding care as punishment is not how our health system is supposed to operate. Reciprocity gives us a clear way to respond. So if someone is contributing despite their legal status, we still have a moral obligation to protect them. And this is what justice requires. So just to conclude, I think we're in a moment where migration enforcement is reshaping health access and where exclusion is increasingly being normalized. And in this moment, I think the reciprocity gives us a clear ethical standard. It tells us membership is social, contribution creates obligation, and denying care to contribution is not fairness. And there's also moral inconsistency there. And I think it raises this important normative question. So what kind of society do we become when we accept people's labor, their taxes, and even their organs while denying them the care that they need to just survive? So I think this is when this becomes an issue, a justice problem. I'll leave it there, and I'm happy to answer questions later. Thank you.
Thank you, Thalia. Altaf.
Thank you. I am telling about was great remarks, and so I'm still reflecting on some of the comments that you made. And I'm excited to follow sort of the legal perspective and then the ethics perspective, and then now sort of get into operationalizing some of these best practices for providers and institutions. And I am going to be predominantly focusing on the healthcare space. But I think there are a lot of analogies that can be made to other sectors, including the education sector. So I'm going to start with the emergency preparedness framework that has been used in the CDC, and it's often used in emergency situations like natural disasters or active shooters. All hospitals, schools, universities have this in place, right? And it not only involves a response and recovery after a disaster happens, right? And but it also involves mitigation and preparedness. And it involves that even if the likelihood, right, of a natural disaster or an active shooter is very low, right? We, probably haven't had that happen in decades in some places, but all hospitals or schools still have these in place, right? Because it's part of preparing for emergencies, which is not just response and recovery. And I think this is a big paradigm shift I've been trying to push for since 2016 and the first iteration of the Trump administration. Is that we have to view immigration raids, we have to view immigration enforcement as an emergency, and it is oftentimes, for families and for communities. And so with this framework in mind, we think about that it's not just waiting for something to happen and dealing with its aftermath in a reactive way, but that we have to take actions in a more proactive manner and think about this mitigation and preparedness part of the cycle. And so this can happen both at the interpersonal level as well as the institutional level. I'm going to start with the interpersonal level, which is where most of us operate, and it's most easily within our control. And highly recommend the Sanctuary Doctoring Toolkit that was developed by several physicians and a bioethicist, Mark Kozowski. And it's a wonderful, wonderful resource. And it begins with establishing dialogue by having messages on brochures, signs, or buttons. Here's an example from their toolkit. and language in a brochure that they have. So it says, if you'd like to talk to your doctor about problems having to do with immigration, just take this sheet into the exam room and hand it to your doctor. And what I love about these examples is that it lowers the burden for patients who may want to bring it up, but may not have the language to do so, or they're not sure how to bring it up or whether to even bring it up. And so this sort of lowers the burden for them. The other elements of the toolkit is offering reassurance, right? So telling language around, telling them that they're not alone, that you won't document immigration status and medical records. And importantly, it links to resources for people, and then in some cases, even planning, right? And I'll get into an example of another helpful resource here in terms of helping families potentially prepare for deportation or family separation. I think some other things to think about is that it's not just in conversation, but that of how we're talking to people, but also what we're documenting. But I again want to highlight that it's I always say that we should not be asking unless there's a clear benefit to the patient, because it's very traumatizing. It's triggering for people to have to think about this. And for some of you may be familiar with trauma-informed care, the principles of trauma-informed care. And there are these 4 R's of trauma-informed care, and the last R is resisting re-traumatization. And I think that that's very important here. And so I implore people to, if you're thinking about asking about this in an encounter, is, are you asking because you're curious or because it's necessary for their care and it will have concrete benefits for them, like giving them specific resources? And then, so if there isn't a clear benefit, right, if you don't have a clear answer to the why you might be asking, then I would say do not ask. But if you do ask, and it does come up, then the next thing to keep in mind is that this should not be documented in medical records. And again, here asking the same questions: is it relevant? Is it absolutely relevant for clinical care to put that detail? Or is it actually the reality of other things like their country of origin that might give them different exposures? Or is it the fact that they were separated from a family member that might be relevant to care rather than their immigration status? I think another thing to ask is about whether you've upheld the principle of informed consent in terms of risks and benefits to the patients, right? Many risks are unknown or hypothetical, like law enforcement potentially accessing medical records through a subpoena, but there are other less egregious consequences like stigma or discrimination from other healthcare team members, right, who might see that information and be biased in their interactions with a particular patient. There are alternatives that we can use in medical records. And I think the take-home point is that good or bad documentation can either assist or harm a patient seeking legal resources. And we have to think about medical records as being potentially used in both criminal and civil cases. And so on the interpersonal level, I just want to highlight that it's not just about interactions, right, in terms of conversations that we're having, but it's also about documentation and what we're documenting. But there are actions to take at the institutional level. I think it's important to keep in mind that institutions are not inherently neutral. They can actively participate in programs or have policies that help patients, or they can have policies that harm patients. And I will say here that it's not just through acts of commission, but omission as well, right? So meaning the absence of policies can also harm patients as well. These are from our Doctors for Immigrant Toolkit that was launched in 2017 after interviews I had done across 5 states that have the largest undocumented immigrant populations. This was across about 30 institutions that were implementing various policies and actions to protect and welcome their immigrant patients. And so we and I was very interested in sort of how were hospitals or clinics operationalizing this idea of sanctuary in the hospital or healthcare setting. And there are various things that can be done, including having explicit policies in place that outline what should happen should immigration enforcement show up. And so, for example, at some institution, this might be calling overhead, like saying, oh, Mr. Johnson is here, and that flags for everyone in the institution that immigration enforcement or law enforcement is on the premises. This is having clear numbers or pagers in place on who to contact should immigration enforcement show up. So having a clearly designated, typically attorney or someone, some other counsel that people can reach should this happen. And this was a sort of a newer guideline that was just published a few months ago in partnership between NILC and Physicians for Human Rights that outlines some of these further, including some of the legal protections and principles that remain in place, like the Fourth Amendment that Matthew talked about, and principles like the right to remain silent, that again, even in the absence or the rescission of the sensitive locations policy, these principles remain in place and allow and give some guidelines in terms of what we can be doing. So Matthew already mentioned, for example, that the Fourth Amendment puts limits on searches of private areas versus public areas. And so one of the things that hospitals can do is review their public and private areas and have clear signage up. So this is from our toolkit, but you'll see, for example, that here's a sign that says that this area is for hospital staff, patients, and visitors only. Or only patients and their caregivers are allowed beyond this point. And even just sort of simply having sign like this makes it such that if immigration enforcement, law enforcement shows up, that they cannot enter these private places without a signed judicial warrant. And so this is an example of an institutional undertaking that can be helpful. Other things that we talk about is, providing know your rights education, right? This can be in waiting rooms. You can place it in bathrooms where it's more private. It can include things like family preparedness plans, and this is a really wonderful toolkit through the Boston Medical Center that's publicly available that goes through with parents things that they should be keeping in mind or asking, like, do you have relevant medical and educational documents? What are the things, who should mail be forwarded to? And again, asking them all these questions. In our toolkit, we sort of highlight all these different sections. I think for the sake of time, I'm not going to go through all of them. But I just sort of want to highlight one of them, which is that we also have to be thinking about immigrants who are healthcare or part of the workforce, the healthcare workforce. About 20% of the healthcare workforce are immigrants, and as just as much as we're thinking about things for our patients, right, this also affects healthcare work staff as well. And so we have institutions should be mindful and being proactive about this, not just for the sake of their patients, but also their workforce. And so I'll end with that and look forward to the Q&A in terms of continuing this conversation further in terms of how we can work with our patients to meet their needs.
Thank you so much to all three members of our panel today. I am going to try to sort of synthesize some of the questions in the chat or submitted through the Q&A. And if you have more questions, please send them through the Q&A. So the first question, and Matthew, I think this is probably a question for you. Are there legal limits to the protections that can be offered to immigrants in the healthcare or education settings? And how can we navigate those limits?
Sure. Thank you. And there are a couple of questions. I know this relates a little bit to HIPAA, which a couple of folks have mentioned in the Q&A section. So first, I'll say, as far as HIPAA goes, HIPAA, relates to healthcare, protects healthcare information, and there is HIPAA does not prevent. It only puts restrictions on what the healthcare provider can do. So essentially, it stands for the general principle of not sharing private health information, which means healthcare professionals should not be voluntarily sharing any information, should not be calling ICE because they think one of their patients might be undocumented. There is a law enforcement restriction, exception, but that exception only allows under certain circumstances. So if the police do have a warrant and are requiring information, then a healthcare provider is not violating their HIPAA obligations by sharing that when compelled by law enforcement. Otherwise, it is really the Fourth Amendment that governs what folks should do, how folks can protect their space legally from having immigration enforcement either enter their space or access their their private healthcare information from their patients. There are some questions I see about, what healthcare providers can do if they do see immigration enforcement happening in their facility, even if they, may have some concern over their patients' safety. What I would say is that a healthcare provider should not interfere with an arrest being happening. They can object and should object and share why they are concerned and why that should not be happening if they feel like there is a healthcare concern. And if immigration enforcement does still do so, they should document what occurred so that there is then a record of that can be brought up later, but should not be interfering with that action.
Can I just add some points around the documentation, because I think that's so important. There might be situations, and I'll say probably happens more commonly, is if someone comes in custody and they are under, let's say, CBP or ICE custody, and they're being brought into the hospital. And sometimes, for example, they might have handcuffed the patient and you're asking them to take the handcuffs off and the people are not listening to you, right? And that has certainly happened. And I think in those situations, again, documenting very clearly and sort of saying, like, you're interfering with me providing medical care, getting their name of who it is, and documenting that in the medical records, because those things can later be used in legal cases, right? As I talked about, that medical records can be used whether it's in criminal or civil cases. And in this situation, I have I think there could potentially be some benefits if that's documented and that person is able to retain an attorney and talk and sort of have that as a demonstrative way of how they might have been interfering with their care.
Thank you. I'm seeing a couple of questions in the Q&A from social workers who are asking about documentation and also, maybe asking about immigration status because it's important to know a patient's immigration status in order to connect them with community resources, but also concerns about connecting them with community resources that maybe you don't know are perfectly safe for them. So Altaf, I was hoping you could comment on those two questions.
Yeah, so I think it goes to the point I talked about is, are you asking because there's going to be some clear deliverable, right? And I think in that situation, right, because there might be specific resources that they may or may not qualify for, then it does make sense to ask, right? I would say in those scenarios, being very clear about why you're asking, it's important, right? And again, providing reassurances. So to say that I'm asking because it could influence your eligibility for certain programs, or I might be able to connect you to specific resources for people with different immigration statuses. So that's why I'm asking, right? Rather than having someone in their mind think, oh, this person's asking because they're going to report me. So being very clear with that and leading with that to assuage fears that people have. And then I think the other piece is, yes, even though you might ask that information, not documenting it. And so I think in some cases, again, you can just write alternatives like this person was not eligible for X program, right? That's not sharing their immigration status, but it's communicating that they're not eligible, and that can be documented in the medical record. And so I think there are ways that you can ask right? Because there's a specific reason and benefit for the patient, but then still not document while being able to communicate what's needed. And I do see that question, Rachel. I'll just answer it because I think I see someone asking about the ambient, the AI. And I just had clinic this morning and used AI to do. So I'm certainly like using that in my clinical practice. I do think because there are some uncertainties, and I very much operate by making sure people have informed consent, right? Even when you use AI, we're consenting them to use that. I think when it comes to certain sensitive topics, I personally like, I have it on my phone. I don't know how it works at different institutions, but where I am. And so I will pause it and I'll say, I'm going to, and then you can like restart the recording again. But because I think there are uncertainties, like we should be proactive about that, and particularly around conversations like this. I'll give another analogy if that's okay, where sometimes I have done the pausing is in the context of like intimate partner violence. And so if that's come up in clinic, I will pause, or I might have a specific conversation to say, is this something that would be appropriate for me to put in your medical records? Who's able to see it, right? If I'm writing that this person is, for example, subject to intimate partner violence, but their partner who's committing the violence, seeing their records, right? I don't want to subject them to harm. And so in those scenarios, I do similar thing where I pause it, I have that conversation explicitly, and then I can resume the pausing. So I think we need to be thinking about that, including in the context of the AI documentation for our notes.
Thank you.
Just, I would, a couple of things just to add as far as approaches to, asking sometimes delicate questions about people's status. And this doesn't always apply, but in some situations, what we find effective is to, instead of asking somebody, what is your status, present an option, present like what may be available for somebody, and ask, is this something you would be interested in? Or anytime that you can, provide something that doesn't require, such as, there are a number of healthcare, or there are a number of, food pantries that are able to provide food for families, even if the families don't have immigration status, if they're not, or even if families cannot get SNAP, for instance, you could say something like, even if families can't get SNAP, they can provide. Would that be something you're interested in? And another thing that I would just say is that the way to prepare to have those conversations begins much earlier than the point where you're asking the question. By being trusted in the community, by being known, you are already building that emotional trust with the individual, by having people that you work with that maybe are from the community, by having people that are able to speak the language of the folks who are coming in. All of these things help people to see you as not somebody who's a threat, but as somebody who is somebody that they can trust.
Thank you. Thalia, there's a question in the chat for you. Do you have thoughts on incorporating member-driven justice conversations in organizations that are self-consciously stripping out curricula or CEU around DEI concerns?
I think that's a very good question. In my view, I think this is something that can be integrated to sort of like the ethics curriculum, so to speak. So it could be something that can be thought of as, for example, like teaching it as a part of a core ethical issue, not sort of like a policy add-on, but something that can be thought of in case studies, in sort of like the medical social work, public health space, sort of what are the consequences of access refusals, trust breakdowns, as Matt was articulating. What are the consequences of misinformation, right? What are the effects of that in the medical space? And so I think it fits nicely in the ethics curricula. And this is something that we can do. I know there's a lot of, ethicists and people that are interested in this space as well, and a lot of educators. So I think that could be one strategy.
Thank you. I have a follow-up question for you, Talia, which is, do you think that there's a role for bioethicists specifically and health humanists in navigating these challenges? And what can the membership of ASBH do in their professional or personal capacities?
Yeah, such good questions. So I think, first off, and I think Matthew and Dr. Saadi are just like excellent examples of this, of working with their institutions and in their institutions to provide just better practices and guidelines, and very localized. So really understanding what are the needs of the specific communities that they're serving. There's so much variability in policies at the state and local level, and I think this is something that we very much need to be in tune with. And many of us, if you're in any type of advisory board or advisory processes, to really make sure that you're speaking about the affected undocumented patients, that this is something that's discussed. I think that's really something that's important. I talked a little bit about misinformation, but I think as a community, we haven't done enough to really study, understand, or advise what we can do to tackle misinformation and how this is impeding access to health for the undocumented population. So just more research and dissemination around that, and also working with organizations that tackle misinformation, I think is super, super important. And I think we really have a responsibility to ensure clear, compassionate, and accurate information that this reaches immigrant communities, but that we also highlight it as it emerges in the research. So when we see something like, 67% of immigrants in California needed to see a mental health provider but didn't, that we don't just include it in our research and mention it as a statistic, that we raise this as an ethical concern, and that we highlight it and we explain again what are the unfair outcomes of these types of yes, statistics, but like what does this really imply? And just keep working if you do, or if you don't, get involved with, I think, the safety net community health centers. I do a lot of work with them. I'm sure Dr. Saadi knows a lot of good resources of how you can get involved as well. But I think places that provide culturally compassionate, concordant care, regardless of legal status, and finding ways to support those spaces is really important. And using your voice, of course. Thank you.
Can I make a comment off of something Talia said, which was around the variations in the local setting? When I think when I started initially doing interviews across different institutions, but still continuing to see that now, is that you can still have a lot of these policies in place, but how public you may be about it, right, as an institution can vary. I have seen some incredible hospital policies in the Deep South. They're not very public about it, right, but within the institution, within their internet, right, they are sharing it. And I saw a colleague who is in the Deep South who shared me their hospital policy, and it's better than the hospital policy we have in Boston. But certainly, some places, for example, in California, have been much more public about it, right? Or they post it and it's publicly available. But in other states or in other contexts, there is more fear about the local context and what repercussions particular institutions might have, right? And so in those places, it's private. And so I think that can happen, right? You can have really helpful institutional policies or things, and how public they are can vary depending on the context.
Thank you. I've noticed today we've talked a lot about institutional policies, and obviously we've talked a lot about federal policy. And I'm wondering if the three of you can think of any realistic and achievable policy changes at the state or local levels that you think could mitigate the harms of this federal policy that we're seeing.
So I can jump in with that. There's a couple of bills that I've worked on this year with folks in Maryland and Colorado in particular, and there's some similar policy in California that seek to create state laws to take steps toward reintroducing the concept of protected areas or sensitive locations. They're state-based sensitive locations laws. The state can't prevent law enforcement from entering, but what they can do is they can require facilities to have a policy and to implement that policy, so that places like schools and healthcare facilities are invoking their Fourth Amendment rights to the fullest extent that they can, and sometimes with some, Colorado in fact has some consequences for not doing so. So there are ways to recreate that. Otherwise, we're in sort of a little bit of a difficult moment. Right now, the federal government, through the reconciliation bill, is considering both drastic cuts to the healthcare system overall, but also access for immigrants, also retaliating against states that have chosen to cover additional immigrants. And so these are things that I would have generally said in the past are things that you can do at the state and local level, which are to cover additional folks, using state money. It's a complicated time for that right now because of the ways that the government is seeking to punish those states. And there was a recent information about the recent disclosure that the Medicaid system was sharing information about enrollees in those states. So it's a little bit of hold tight on that. What I'm concerned about right now is like, what can we do to create the most safety at hospitals? So an issue I'm going to be looking at in the next legislative year is recreating these safe spaces programs at the state level.
Thank you. Altaf or Thalia, any policy change you would like to see, either state level or locally? It's okay if the answer is no.
No, I mean, I think Matthew articulated everything very well, but I think it's not only the policy, but also just what gets implemented in practice. And I just think like wider dissemination of awareness about people's rights and protections is urgently needed. And so I think that kind of complements what gets passed in legislation to what can actually feasibly be implemented at the same time. So more on that, I think.
Thank you. There is a question in the chat about sort of the idea of the chilling effect that undocumented immigrants might be afraid to seek help and then would present later with more complex medical issues than they would have had if they had been able to come earlier, and that this might drive up medical costs rather than saving medical costs. And this, just taking moderator's privilege, is really interesting to me because I think a lot about the sorts of practical reasons we give when we're justifying policies as opposed to the moral ones and how they interplay. And so I would love it if you could comment on when we're making these sort of advocacy moves, when we're trying to advocate for more just immigration and health policy, how do you marry those arguments, right? That this is morally the correct thing to do, but also like practically it is bad for everyone when we have these policies. So how do you do that in an advocacy space?
I can jump in. Sorry, go ahead, Matt.
Go for it, Thalia.
So I mean, I think that again, and it depends on what's happening. But I think for example, there's many cases where we've seen just like the effects of infectious disease, for example. There's something that happens to the individual that affects communities, that permeates societies, and that affects everybody. So it's not about, when we're talking about health, I think we have to think more collectively in terms of what the effects and the harms are when we exclude particular communities from getting access to care. That's number one. Number two, and this is, just based on like cost effectiveness, if we invest in prevention and not only and preventative care. And if people are able to go and see their primary care providers, this will prevent chronic conditions further down the line, which are costly at an exponential level. And so chronic kidney disease, diabetes, you name it, like this becomes very costly to everybody and the healthcare system and society and so on. And I think importantly, something that we need to think about again is mental health, and we haven't done that enough. And so when people are constantly exposed to stress, to anxiety, longitudinal data suggests that this does have an effect in cognitive decline further down the line. And so I think, again, like this is something that if we're living with people that are constantly affected in this way, and I do think that stress and anxiety also permeates when, across like communities, this is something of an effect that I think also affects everybody at the psychological level. So 3 different examples, but I'm wondering what others think.
I definitely agree with the question, and that I would also note that there are medical professionals who can speak better to the question of exactly how that plays out with not treating illnesses. We do have a proven track record from issues like the change in policy related to public charge in the first administration that does indicate that people do seek services less when they fear repercussions from immigration. So that is something that we know. And as far as Rachel's question about advocacy, that is, I will say that is sort of an age-old question, like how to reach some folks who really are swayed by economic arguments without turning people into numbers. What I would say is a couple of things. One is that I don't think it needs to necessarily be an or. I think of it as an and. I think that people should speak when people speak authentically to their own experiences, that is when people are most at the height of their power. So if you are a person for whom your experience is that the healthcare system becomes more costly when these medical situations aren't treated early, then that's something that is if that's your experience, that's what you should share. And we should also be making space for folks who are affected by the system to be able to share their story. I always try to, when we're discussing things, like if you can put a face to, or a story to an individual, or to a situation, so you're not just talking about the cost, but you're also bringing humans into it. And if similar to the idea of like not asking for information, if you're not without saying how you're planning on using it, how are you using that information? So if you're quoting statistics, and if you're quoting like benefits and what people their economic benefits, like, are you saying that because you are trying to share something about this community that's authentic and that supports a moral argument, or are you just turning people into numbers?
I just have very minor comments to add to that, but definitely highlighting what Matthew was saying around really, and something that I tell sort of trainees and folks that I work with all the time is that every data point is a human story, and not losing sight of that. And I think that's very important whenever we do communicate numbers, that it really should go hand in hand with the human stories that are attached to them. I think the one addition that I would make is really trying to expand our conversation about the impacts of this beyond undocumented immigrants. We know that there are thousands of families that have various members with different mixed immigration statuses, right? And this has ripple effects through entire households and communities, that it's not just the person who's undocumented who's afraid, right? But it might be their child who has U.S. citizenship who is afraid, right? That it might be a spouse who has documentation, right, with maybe a legal permanent resident, but then another family member doesn't, right? So we really need to expand our communication around this as not just being something that's affecting people with or without documentation, and that we are seeing even people with documentation being targeted by this administration. And so I think that that's an important sort of expansion of our conversation that needs to be had.
Thank you so much. And we are right at the end of time. So I just want to thank you all again. Matthew, Thalia, Altaf, thank you so much for your time, for coming and sharing your wisdom. And this recording will be made available on the ASBH website, and we'll also be sending out many of the resources that were shared in the chat via email. So thank you all so much.
Pleasure. Bye.
Thank you.
Bye.